if you will, in heparinized pool of, you know, it's amazing in a number of ways for all of us. Things that we had to work out together. Your thoughts on leaving at least around that patient the stent in for 3 months almost? Just thoughts and
Yeah,
considerations.
so there's managing that stent is, I don't think there's any real, we can surgery foo or physiology foo whether leaving that stent in place is a good idea because it prevents strictures, seals against leaks, it may cause erosions, but I think ultimately that on a patient-to-patient basis, it's going to be really what that reconstruction of everything else looked like. Was not obviously a guy with, a 1 centimeter caustic stricture or something like that was otherwise, a 25 or 30-year-old healthy individual where you could just cut out a piece of esophagus and plug this thing in. Because in that case, there are other reconstruction options, right? And so it's a little bit hard to convince people, not only to convince people, but to convince the regulators that that's an appropriate case to try this on, at least as a first go. Unfortunately, the ones that are going to be the first, first in man are the ones where there are no other reconstruction options, and that it's very difficult to predict, and the situation is extraordinarily complicated. I think leaving the stent in for that period of time was quite reasonable. I mean, the pericardial fat pad on this guy was huge. It should have kept everything well separated. Would the leak have happened with or without the stent? Well, was the leak better with the stent in place and less contamination of the pleural cavity? I don't know. And I think that, yeah, go ahead.
So I think it's a heroic operation that you did. It's really fantastic. My one question is, if you had used a vein graft instead of Gore-Tex, do you think the outcome may have been a little bit different?
Yeah, I don't know the answer to that. I think probably. The issue with the vein graft even in the thoracic cavity is I mean, I didn't do the cardiac help with the cardiac part. I was there for it, but our cardiac group has had poor experiences with using non-rigid grafts, even in the thoracic cavity, that they have a significant amount of collapse to them after all the edema comes in and all the swelling from the mediastinum, and they've actually had poor experiences with IVC thrombosis, suprahepatic IVC thrombosis. So while it's routine for them to use ring graft in the abdomen for that purpose, they also tend to do the same thing or some other semi-rigid prosthetic even in the chest. In this particular case, I think it would have been quite reasonable. But we thought there was enough soft tissue between the two. But given that, the contamination of the pleural space probably seeded that IVC graft, yeah, I think that could have been ameliorated by using, allogenic material. But
in hindsight, though, it's
yeah, exactly. Because the other option would be, you'd say you did that and they didn't have a pleural, esophagopleural fistula, then I think if he didn't have the esophagopleural fistula, it would have been fine either way. But if he knew he was going to have the esophagopleural fistula, then yeah, in hindsight, allogenic would have been the way to go.
Now, just for technical things, did the esophagopleural fistula happen right away, or was it delayed?
So
I missed that part.
We've not seen any evidence that we can tell going backwards. The earliest evidence of possible contamination of the pleural space was about a month out. He had a prior CT scan that we did, and it showed, a little bit of hemothorax on that right-hand side, but no evidence of infection. So it looks like it probably occurred, to the best of our guessing, probably a month or so out.
Okay, thank you.
Yep.
Any other questions? Great, John, that's great. Thank you very much.
Yeah, sorry it couldn't have been better outcome for him, but I mean, we got him an extra year with a bad cancer. So all being said, I think we did do him did do things right by him.
Well, and I'm sure his legacy is going to be the fact that he was the first one to receive this implant, and it seemed like he was invested in the research and the process. So I think that's something that
he and the family understood that. You know, there were extensive discussions that were had with the guy. It's, you know, this has never been tried. We have no idea what's going to happen. We know based on about at that point in time 6 pigs with, you know, 6-month follow-up that it seems to work okay in pigs, but that's about what we know. But he wanted that tumor out pretty bad, and that was really the only way to possibly even put his esophagus back together.
Incredible.
And I think it provides a lot of great information that we can see that the tissue regenerates, it works in the human being, and that's going to really help to bolster the story with FDA for sure.
And all the things that we did, you know, with that, with the container and shipping and things that we learned with UT and how to do it. And now, if you will, it's turnkey.
It is.
We believe it's turnkey now, how it's kept in. And then the other one was the surrogate. To be able to have that little surrogate next to it and how to be able to, you know, to use that. Yeah. So that's a new piece too.
Yeah, there were all kinds of little logistical hurdles that I didn't appreciate that we were going to have to surmount on both ends of, you know, once you have the fat in hand, how do you ship it to UT in a reasonable way? Once it's at UT, how do they, you know, they can do their MSC stuff because that's fairly turnkey for them. But then getting it on the CEI was not, and then, or on the implant was not, and then getting the implant back. How do you ship that? Do you need a courier? Does that courier need a TSA excuse or an exemption? And is there any guarantee that the TSA is even going to listen to that because they don't need to? And there was all kinds of logistical hurdles. And if he looks at it, is it going to get contaminated? Is it going to get too warm? You know, there are all kinds of little things that you don't necessarily think about that when you're, well, we're just going to take the fat and ship it to UT and they're going to send it back, is definitely not how it was going to happen.
And truly, thanks to the efforts of, you know, yourself and Dr. Weigel, John, our company kind of grew up that moment. We kind of pulled ourselves together. We knew we had a lot of things that we had to do, and really everyone just started kind of moving in the right direction. We were making stuff, you know, we'll get to that in the hardware store. We're like, no, this has to be a traceable piece, you know. And so, and then we did all of this under GMP conditions. We did all of this under regulatory and quality aspect. And so we put a lot of that. I don't know if Tina's still on the line. She's actually on her way to Jerusalem, so she's heading down there right now. But we also had the worst weather come in, typical Murphy's Law, the worst weather come in when we were trying to move it back. There was no flight getting on. We had another chartered flight, you might recall, standing by. Remember all that stuff with airplanes?
Yeah, it was definitely a learning moment for us.
It all went through.
Well, Bill, it was Jay Candy, just from an overall perspective, you know, you can almost boil this down to seed and soil and the heroic effort that went into combining the seed and the soil. But if you look at him, he was almost the worst soil imaginable in terms of being a candidate for regenerative medicine. And in spite of that, and the fact that he provided the cells himself, by definition, they probably weren't the world's greatest cells.
Yeah, Weigel and I had that conversation. The conversation we had was, if this guy can grow esophageal tissue back, pretty much anybody can.
Well, that was exactly where I was going, because there aren't going to be many circumstances much worse than this.
Right. You would think that in an ordinary clinical trial, he would have been excluded by a variety of these other problems.
Oh, absolutely.
But they obviously made that much more difficult.
My brother and I did the world's first cartilage, tissue-engineered cartilage, in a 100-year-old man that came into the hospital with a broken hip. And his hip itself wasn't pathologic, but it was 100. So the question was, if you put his chondrocytes on a scaffold and then put that cell scaffold into a thymic animal, would it form cartilage? So the short answer was yes, it did, but it was a really crummy cartilage. Not the same. congratulations. I think even from a humanity point of view, making this massive effort and having them understand and not only agree, but want to participate is really a wonderful.
Yeah, we often get the question why we can't find patients, right, for something of this nature. And the answer is the right guy or girl has to walk through the door.
Right. Yeah. That is exactly what I was going to say when we come to talk about the protocol, that the key problem in this type of a study at this stage is to find a patient who's willing to go to consider enrolling this. And the patient asks, how many times have this been done? Or how many times have you done this? Well, I have never done this. How many times has it been done? Well, it's really never been done, and is still willing to try that. And I think that finding the right patient is extremely important. So from that standpoint, this was the ideal patient.
Right.
Absolutely.
If it can work here, it can mitigate a lot of questions at FDA.
And I think the important thing coming out of that for BioStage is that the biology was shown to work.
Right.
The biology of the CEI was shown to work in this situation. You did grow an epithelialized segment that allowed at least pureed food to get into the system.
That was a question I wanted to ask, is when did he actually start eating?
I want to say about a month or so out. I did gloss over one thing. At the time of the adipose biopsy, we belt and suspended and gave him a G tube because we wanted to be able to drain him from above and below if needed. Because we do have some longer esophageal stents that can span basically from, and we have done it in some people, all the way from the cervical region down past the GE junction, just to provide a fairly complete seal. So we gave him a G tube at the same time, and then immediately, well, maybe a week or two post-op, we converted that to a GJ. So we were able to do jejunal feeds, but by mouth, I want to say around a month out. And it's a routine practice for esophageal stents that they can't really go past a pureed because of migration.
Yeah. But I was just wondering if it correlated with the time frame for the fistula.
Yeah. So I think that there's a lot more saliva that goes past there than people appreciate. So I think if they're going to contaminate it, I don't necessarily know if the diet really contributes that much compared to them just constantly swallowing saliva. So I don't know the answer to that, but I don't know if swallowing food past there really adds that much more contamination than what they normally swallow for, say, spit in a day. But I don't know, because I don't know how much spit you swallow in a day, but it's probably a lot.
With the oral flora.
Yeah, exactly. And I mean, there's everything bad in there.
Yeah, yeah.
Great, thanks, Jonathan.
It's absolutely my pleasure, and thanks for letting us participate in doing it.
Oh, great. Jim and I will see you next Monday.
Look forward to it.
Great.
But I'd like to